Good afternoon. Okay, so this is recorded lecture on a single contrast BE, and we are in chapter 13. This starts on page 488, 490, and this is still in the section of the lower gastrointestinal system. And we've already discussed last time the small intestine and the small bowel series, the enterochalasis, and the intubation method. So this is going into the barium enema, where we actually look at the large intestine. So when we start off, again, just to put it in perspective, when we look at the entire alimentary canal, starting with the mouth and ending at the anus, we've already discussed everything from esophagram, upper GI, and small bowel series. And now we're going to begin with the single contrast BE. And everything so far has come the normal flow, like beginning at the mouth and being ingested and then following it through. But the barium enema is unique in that this actually takes place retrograde or backwards, meaning that we start by inserting an enema tip into the rectum, and we actually fill the large intestine backwards with barium all the way until it either does one of two things. It either fills the appendix, and then we know that we've reached the end, or barium will actually reflux back through the ileocecal valve into the small intestine. The one thing I want to point out is notice how the large intestine kind of lines the periphery of the abdomen. We've discussed that before, but that's actually going to be the focus of what we're looking at today. A barium enema, or a lower GI series, or a lower colon series, as they're sometimes called, you can see sometimes it's written out as a barium enema, or simply shortened to the initials BE. The purpose of a BE is a radiographic exam of the entire large intestine, beginning with the rectum and going all the way around through and into the cecum. And we can either do a single contrast, which we'll talk about today, or you can also do a double contrast study. And that, remember, anytime there's double contrast, it means two. So a double contrast is where we use air and barium. And a single contrast means we use one contrast, typically the positive contrast media. So we either use barium or the water-soluble iodinated contrast media if they're not able to have the barium. When we look at the large intestine anatomy, this is actually on page 490. And notice I have here, we're looking at the colon versus the large intestine. Now, the large intestine, a lot of people use these two terms interchangeably, meaning they use both to reference the same thing, like the colon and the large intestine are one and the same, but they're actually not. The colon actually consists of 4 sections, and they're labeled here: the ascending colon, the transverse colon, the descending colon, and the sigmoid colon, in 2 flexures. You have the left splenic flexure and the right hepatic flexure. Those are the only parts that make up the colon. So you have the 4 sections: ascending, transverse, descending, and sigmoid colon, plus the 2 flexures. That's the colon. What it does not include is, it doesn't include the cecum, and it doesn't include the rectum. Okay, but when you talk about everything, all the way from the rectum all the way around, including the cecum, which is the blind pouch, that is the large intestine. So a barium enema actually is a study of the large intestine, meaning we have to visualize everything from the rectum all the way through the sigmoid, up the descending colon, around the left splenic flexure, across the transverse colon, through the right hepatic flexure, down the down the ascending colon, including the cecum, until barium actually refluxes through the ileocecal valve, or it fills the appendix if they still have one. And notice that's the vermiform appendix, which means worm-like. So they're not the same thing. They cannot be used interchangeably. So the large intestine includes the colon, but the colon does not include everything in the large intestine. When we look at the cecum and the terminal ileum and the appendix, the cecum is basically a blind pouch, meaning it's the very bottom portion of the large intestine. So when it comes down the ascending colon, the cecum is kind of at the bottom of that. And if the patient has their appendix or the vermiform appendix, it actually comes off the cecum. It kind of hangs worm-like off the end. If the patient does not have an appendix, then obviously you would not see it there. It's probably been surgically removed. Coming into the cecum, we have the terminal ileum. Now this is the last portion of the small intestine. Notice the spelling of ileum, where it dumps into the cecum, which is the first portion of the large intestine. So when we look at a barium enema, one of the two ways we know that it's deemed complete is that barium either refluxes back through the ileocecal valve or barium fills the appendix. Either of those two scenarios would deem the barium enema complete. When we have the appendix, if it becomes inflamed, the condition is called an appendicitis, and a lot of times that can be possibly seen on a radiograph, but a lot of times they'll actually diagnose that with a CT scan, and if the patient has to have that removed, then it is termed an appendectomy. When we look at the barium enema, this picture is actually on page 490 of your textbook. This is a double contrast study, meaning you can see the barium, and then you can also see that there is air in here because we only see the outline of the intestine with barium, and then the entire hollow portion is actually full of air, which distends it and causes the barium to stick to the haustra or to the lining membrane. Remember, each of these sac-like pouches is called haustra, and it's pulled into those pouches by the Taenia coli, which are the longitudinal bands of muscle that actually pull that in. So when we look at barium enema, single or double, we start at the rectum, and there's an enema tip. You can see right here, this is the enema tip that has air in the retention cuff. You can see the tip portion is right here, and then air in the retention cuff. And then you've got the rectum, you've got the sigmoid colon, the descending colon, splenic flexure, transverse colon, right hepatic flexure, ascending colon, and cecum. And then the ileocecal valve would be somewhere in here. Okay, so it includes looking at all of that. Like we said, on the lateral view of the rectum, just so you can put it in perspective, this is the posterior aspect of the patient. You can see the sacrum right here along with the coccyx, and that correlates to where the rectum actually is. The rectum sits anterior to the sacrum and coccyx. You've got the rectal ampulla, and then you've got the anus. This is the front of the patient, this is the back of the patient. And then large intestine, like we said, some of the differences is the internal diameter of the large intestine is greater than the small. There's haustra, which are these sac pouches, and those sac-like pouches are formed because of the Taenia coli, which are the 3 bands of longitudinal muscles that actually pull these pouches into shape. And as far as relative position, large intestine is the periphery of the abdomen, small intestine tends to make up the interior of that abdomen. Now, when we look at the air and barium distribution, just like we did in the stomach, this is important to recognize where the air is versus where the barium is. And this actually comes from page 491. And you can see that air is represented by the black and barium is actually represented by the white. And notice when the barium is in the transverse colon, notice the degree of the range of motion that this has compared to when there's just air in there. Barium is very dense and heavy, and the transverse colon has a lot of movement to it. So it's the most flexible portion of the large intestine. So when a patient is supine or lying on their back, you can see the enema tip in here. But when they're lying on their back, you can tell that the sigmoid and the rectum this is where the actual tip would be. But on that, you can see where this would be the descending colon. This would be the ascending colon. Those are both full of barium. Okay, so ascending and descending colon are mainly full of barium. You can see the transverse, the sigmoid, and the rectum are mainly full of air. When the patient flips over, that would be the opposite. When they're prone, you can actually see portions of the sigmoid and the rectum have air, along with the descending and the ascending colon. Okay, notice again the barium filling the transverse colon is very heavy, which causes it to have a lot of motion in there. It's the least attached portion of the large intestine. So recognizing where's barium versus air in the intestine is important, especially when trying to figure out which image you're looking at, which image might need repeating. It's important to know your anatomy, okay? I think I've said that probably about 1,000,000 times. On the lateral rectum, you can see, if you look on here, the patient's, you can see the head of the femur sitting in the acetabulum here. You can see the coccyx right here along with the sacrum. Okay, so this is actually the posterior aspect of the patient. This is the anterior aspect. So the patient is lying on their left side. They're in a left lateral. And then you can see the enema tip with the retention cuff full of air. You can see the tip itself, which would be coming to the outside. And then you can see the rectum and going into the sigmoid colon right here. You can see pockets of air in the other portions of the intestine as well. Some clinical indications of a barium enema. They reference that, and this actually comes on page, if you're trying to look for this, you can find this on page, hold that thought. This would actually be on page 500. All right, and the purpose of this barium enema is actually to demonstrate radiographically the form and function of the large intestine and detect any abnormalities that might be taking place. So some of the indications we have for this would be colitis, which is an inflammatory condition of the large intestine. And there's a lot of different causes of that. Ulcerative colitis as well. That's a very severe form of colitis that's more common among younger adults. If they're looking for diverticulosis or diverticulitis. Now, diverticulosis is the condition of having multiple diverticulum, and that's the outpouching. So having multiple is diverticulosis. When they become inflamed, that is diverticulitis. Okay, so diverticulosis means you have multiple diverticulum. Diverticulitis is when they actually become inflamed, which is painful. Any kind of neoplasms in the large intestine, they talk about, they're common in the large intestine, and though you can have benign tumors that take place, carcinoma of the large intestine or cancer is a leading cause of death among both men and women. And it's most cancers occur in the rectum and the sigmoid colon. Okay, and what happens is they encircle the lumen or the opening of that colon, producing an irregular channel through it. So radiographically, it can appear as an apple core sign or a napkin ring lesion. All right, and they also reference that both benign and malignant tumors can begin as polyps. So a lot of times when they do colonoscopies, they will actually take out any polyps that are found on a colonoscopy. They'll remove them and they'll actually test them to see if they are cancerous. Okay. Volvulus would be another reason that a patient might have a BE ordered. That is, a volvulus is actually a twisting of the portion of the intestine on its own mesentery. So kind of like when you go to make a balloon animal and you watch them blow it up and then they twist it, the balloon on itself, that's what a volvulus actually looks like. And what happens is the blood supply to that area is lost, and it can actually lead to necrosis or death of that tissue. And if that happens, a lot of times with that necrosis comes the patient will become septic. So very serious condition, has to be corrected very quickly. Intussusception, that would be another reason. Intussusception is where a portion of the bowel actually telescopes in on itself. I usually talk about how a water snake, that toy that everybody's played with where it's got water and you kind of hold it between your hands and it kind of slips through as you go. That's what intussusception is. It's a telescoping of one part of the intestine into another. And a lot of times this happens in infants. It can happen in adults, but it's very common in infants. And what they can do, instead of trying to surgically repair that, which would be a lot on a young person, sometimes what they'll do is actually perform a barium enema to kind of pop that section out. I would much rather have my small child have a barium enema than to have abdominal surgery. And when they talk about appendicitis, a lot of times they will not do a barium enema if they suspect acute appendicitis, because the danger would be perforating that area of the intestine. If they're not sure if the patient has appendicitis, typically they will either do ultrasound or a CT. Those tend to be the modalities of choice to diagnose acute appendicitis, but typically they will not do a barium enema if they suspect appendicitis without ruling it out first. All right, and these are on page 500 of your book. These are some images of ulcerative colitis, which can be diagnosed with single or double contrast studies, but these tend to appear like cobblestone appearance, or sometimes they'll call this, it has a stovepipe appearance. Diverticulosis, remember that's the condition of having multiple diverticulum. And it says, what's the difference between a diverticulum and a polyp? It's the direction of which it goes. A diverticulum is an outpouching. You can see here almost a little outpouching of that kind of sticks out away from the large intestine or the colon. And a polyp is actually inward facing. It projects into the lumen, whereas a diverticulum projects out from the intestine. So the difference is which direction they go. Neoplasm, remember we said that can have what they call like a napkin ring appearance. You know, when you put a napkin ring around, sometimes fancy restaurants will put a napkin ring around the napkin to kind of make it look pretty, but it actually squeezes a portion of the napkin, and sometimes people will call that a napkin ring sign, or it actually does kind of look like the core of an apple, where you've got the bottom of the apple and the top of the apple, and then you've got the core in the middle. A cecal volvulus, remember we said that a volvulus is a twisting of the intestine on itself, which can cause loss of blood supply and lead to tissue death. Okay. They talk about that a volvulus, you can find that in portions of the jejunum or the ileum, but it also can occur in the cecum and in the sigmoid. It says it's more likely to occur in men versus women, and most common in adults 20 to 50 years old. And what they look for is a classic beak sign or a tapered area where the valsite, how that would look during a barium enema. And they tell you that a volvulus actually produces an air fluid level, which you can see on an upright abdomen, which appears to be what they have here. You can see a significant air fluid level. You've got solid lines. So the patient must be upright for that particular study. All right, so we are going to actually look at a barium enema, and this all begins on page 502 of your textbook. Now, the patient prep for a barium enema. Notice this says a light evening meal prior to the exam. I would argue that is not the case. Most of these preps are either a 1 or a 2-day prep, and typically for 48 hours prior to the exam, they are not allowed any kind of food with substance. When I say that, I mean they're allowed like Jell-O. They might be allowed broth, like vegetable broth, soup broth, but nothing with any substance whatsoever. Nothing that the patient's really going to feel great about. They don't get a lot of energy from that. A lot of times they have Jell-O, broth. They can have Gatorade. They can have clear liquids, but a lot of their time is actually spent in the restroom. Notice it says bowel cleansing cathartics, and a cathartic is another term for a laxative. And I would make note of that term because a lot of times on the registry, they like to use that. A cathartic is something that purges, and a lot of times they'll use that instead of a laxative, but they basically have the same meaning. It rids the body of excess fecal material. So they're typically on a restricted kind of diet. They have tons of laxatives or cathartics that they're given. Now, when we talk about these cathartics, we'll look at them on the next slide because there's a couple different kinds. And typically they're NPO at least after midnight. No gum chewing, no cigarette smoking, and then they have to top it all off with having an enema, typically like a Fleets enema, the morning of the exam to make sure everything is cleaned out. It's not a whole lot different than when a patient has a colonoscopy, the prep that they have to go through for that. So I would tell you that most patients would argue that the prep is far worse than the actual exam because it's 1 or 2 days of constant eliminating of feces, and I mean, pretty much it ends up being water by the time they get everything out, but they have to stay hydrated. That's probably the biggest thing that I could tell you as far as warning patients is they have to maintain their hydration because these cathartics and the things that we give them and tell them to take and what we don't allow them to have, it actually dehydrates the patient and it can really mess with their electrolytes. And a lot of elderly patients can actually end up hospitalized from the prep for a BE. When we talk about these cathartics, like I said, it's a substance that produces frequent soft or liquid bowel movements. And there's 2 types. There are irritant laxatives and saline laxatives. Now your irritant laxatives would be something like castor oil, and your book says that they're rarely used. I don't know that that's the case. A lot of your GI docs tend to be old school and they swear by castor oil, so it's usually added in with the prep for the patient. The saline laxatives, those include like your magnesium citrate or mag sulfate. Typically, it's a combination. I mean, usually patients are given not only mag citrate, Fleets enemas, Ducalox, Bisacodyl, which is the generic of Ducalox. They're usually given all different kinds of laxatives to get rid of everything in there. Because if you think about it, it makes sense that we need that entire large intestine empty so that we can visualize, or the radiologist, the fluoroscopist, can visualize anything that's going on in there. Now, if the patient had any of these conditions, which would be a contraindication to cathartics, then they would not have these given to them. And some of those contraindications are gross bleeding, severe diarrhea, a potential obstruction, or any kind of inflammatory lesion. If that was the case, then the patient would not have that. We would have to figure out some other way for the patient to actually empty their large intestine. Actually, it's not on us to figure it out. It's on their GI doc and or the radiologist to figure that out. All right, now the contrast media that is used for the barium enema. This is actually on page 503. It is typically in a single-use closed system kit, meaning once you use this, this would be for a single contrast BE. This would be done for one patient, and everything would be thrown out when you're done with that patient. There is a difference with how we prep the contrast, whether we use cold water or hot water or room temperature water. The fact that it is a colloidal suspension is important. We can actually look at this. When we talk about cold versus hot versus room temperature, that is actually on page 504, just this one point. And it says that there's a huge debate over the temperature of the water that's used to prepare barium sulfate. Some recommend cold water. It says that cold water is reported to have an almost anesthetic effect on the colon, and it increases the retention of the contrast media. But others argue that cold water can actually lead to spasm in the colon, which is extremely painful for the patient. Most experts agree that room temperature water, somewhere between 85 to 90 degrees, is recommended for a more successful exam with the maximum patient comfort. You don't want to use hot water because the potential is there for you to scald the mucosal lining of the intestine. So definitely not hot. I usually tell students to run the water over the inside of their wrist. If it's not too hot and not too cold on the inside of your wrist, then that would be perfect to use. Same way you test a baby bottle to tell if the formula is too hot or too cold. Same kind of process that we go through. Remember that the barium is a colloidal suspension, meaning it will always layer out. It does not stay mixed. So you have to make sure that you shake the enema bag before you insert the tip so that it's not separating prior to you beginning the patient. Now, typically that's not going to be the case because you're not usually mixing this much before tip insertion because you have to check the scout image. So that shouldn't be an issue. When we talk about spasm, colonic spasm, what you can do for the patient, one thing would be to give the patient glucagon. That is a medication that is a smooth muscle relaxer. If you remember that from intro class in chapter 21 when we talked about the drug chapter, that is a smooth muscle relaxer, and that is given intravenously. Now, you can give glucagon to the patient as long as they're not diabetic. Something else that I've heard of, I've never seen done, is that sometimes they will actually add lidocaine or a topical anesthetic added to the contrast, meaning they would pour liquid lidocaine in here so that within the barium it actually has a numbing effect. I've never experienced that in over 30 years. I've never had anywhere that we've done that, but I have had the radiologist give injections of glucagon. So that glucagon is a smooth muscle relaxer, only used if the patient is definitely having spasm and in a lot of discomfort. The radiologist will call for it, and then usually we halt the procedure for a minute. They use a tourniquet to tie off the antecubital fossa or the front of the elbow, and they inject that glucagon intravenously, and it usually works within seconds. The enema tips that we use, those are back on page 503, and you can see pictured here are 3 different tips. You have a plastic disposable tip. This one is actually called an acorn tip because of the shape of the top of that. It looks like a little acorn. And these usually come with the barium enema bags, but notice there's no retention cuff on there, no retention balloon. There's no way for that to stay in the patient. Okay, so if you put that in the patient and it's an adult patient, most likely that's going to slide out. So I've only ever seen used for pediatric patients, and that's called an acorn tip. This is a single contrast retention tip. Okay, make sure you note that. Notice there's one port coming off the side. So this is a single contrast BE tip. On this one, there's two coming off. This is a double contrast retention tip. Now, what's the difference? Well, they both have inflatable retention balloons that we inflate with air once we get into the patient. This one right here, along with this same thing over here, that's how you actually put the air into the balloon. It has a little bag. It's called a balloon inflator that you squeeze, and it actually causes that to blow up. So same thing as far as that's concerned. The difference is a double contrast BE tip has a bulb syringe attached to this tubing right here, so that once you get the barium into the patient and the radiologist calls for it, you actually begin to pump air into the patient by squeezing that bulb syringe. So the easiest way to tell is, does it have one or two ports coming off the side? If it has two, it's a double contrast BE tip. If it has one, it's a single contrast BE tip. And they're just showing you how it looks when it's inflated versus fully inflated. Now, the other thing I would warn you about at this point is that when you're going to be using a barium enema tip, whether it's single or double, you want to make sure you test that balloon before you put it in the patient. You don't want to put that balloon in the patient and then find out it doesn't hold air, because that would defeat the entire purpose. You would have to, if it's attached to the bag, you'd have to throw out the entire bag and start again. But when I say test it, meaning before you get everything ready, inflate that balloon, clamp it off, and let it sit for a few minutes, and then check it and make sure it still has the same amount of air that you put in. If it's got a slow leak or it's not holding air, do not use that on the patient. The room prep involved in a barium enema. Notice you're still set up for fluoroscopy, but the table, unlike the esophagram and the upper GI, the table actually starts off horizontal, meaning the patient's going to be lying on the table. You are going to have to take a scout image, which is a scout of the abdomen, because what you're checking to see is that the patient is cleaned out prior to beginning the exam. So you would take an AP supine abdomen, whether it's one lengthwise or a T-shot or two crosswise, and you would have that cleared with someone prior to beginning the procedure. Once it's cleared, you would bring the bucky all the way down to bring out the bucky shield. You would have your contrast media. You would prepare it at that time. You can see they've got a barium enema bag right there already mixed. And you want to make sure you have either towels or linen, something available for the patient in case they have to lose the enema tip. One thing that is not in this, and they don't really talk about it in the book, but they've come up with it, is what we call a swimming pool. Kind of funny, but if you imagine a little small swimming pool, it actually looks like a ring. It almost looks like one of the rings you would put on little children, like they would put their body in it and it goes around to help keep them afloat, except that the swimming pool that I'm speaking of looks like that, but it has a bottom to it. And you actually blow a little bit of air up in that, and you place that under the patient while they're lying on the table, so that if they happen to lose the tip, or they push the tip out, or in some course of moving around they lose the enema tip, instead of the barium coming out of the patient and going all over the table, it would actually collect in that little swimming pool, which makes cleanup much, much easier. All right, and this is what your patient would look like when you're ready for the radiologist to come in and begin fluoro. So the bucky you can see is down here. It's probably not all the way down in that picture, but you can start to see the bucky slot shield right here. which is brought out. They've got the footboard on the table, which is typically the case in a fluoro room. They've got the patient has the enema tip in. This must be a double contrast BE because you can see the bulb syringe right there, and that is only used on a double contrast study. You can see the barium is all the way down the tubing, probably as close to the patient's rectum as it can be. You can see barium in the bag here hanging on an IV pole, and I would tell you that that IV pole can be no more than 24 inches above the table. So from here to the bag cannot be more than 24 inches. Why? Because that actually, the barium gets into the patient through gravity, and if that bag is too high, then it would go in too fast. So sometimes you might have the bag there and the radiologist might actually ask you to lower it. If it's not going in fast enough, sometimes they can ask you to raise it. But you don't want to start with it more than 24 inches from the table. And that can be found on page 505, right above the summary of the enema tip insertion procedure. It says that the IV pole supporting the enema bag should be no more than 60 centimeters or 24 inches above the radiographic table. You can see they have the fluoro tower across the patient. We've got our lead strips here that protect the radiologist. They've got all the controls up here to control the fluoroscopy. We've got our screen where we would actually watch what's going on while the radiologist is doing fluoro and kind of see what's going on with the patient. Here we have our image intensifier that makes the image brighter than it would without that. So all of that, and this little lever here is how you actually pull this across. And then when you want to put it back, you push that lever down and you push that back. All right, for the enema tip insertion, the patient is actually in Sims position. Remember, we've learned so far that Sims, the patient's lying on their left side, and they've got their right knee bent. And you can see with the patient like that, it actually allows visualization of the rectum. Now, obviously, with the patient having a BE, they would have no clothing on. When you change the patient for this, they literally take everything off and they put the gown on open to the back. You don't even want their shoes on them if you can help that. I wouldn't make them walk barefoot, but I would definitely, once they get on the table, give them booty covers, or just have them take off their shoes once they're on the table, because if the barium leaks, you do not want it getting in the patient's clothing. You don't want it in their shoes, their socks, none of that. So obviously they would have nothing on and they would have a gown over them. But when they bring that right knee and bend it forward and the left leg straight on their side like that, it allows you to have full access to insert the enema. Enema tip, I'm sorry. All right, biggest thing, you want to communicate with the patient. You don't want to surprise them and just start trying to put the tip in without telling them. They can't see you. They're faced away from you, and you're likely back here working. So you want to tell the patient, okay, what we're going to do now is I'm going to insert an enema tip into your rectum. Be assured that there is lubrication on that enema tip to help it slide in a little bit easier. The biggest thing is I don't want you to fight me. Don't push against this. I'm going to have you do some certain kind of breathing where you breathe in your nose and out your mouth to help relax your abdominal muscles, and then I'm going to slide that tip in. I will tell you that once the tip goes in, you're going to feel like you have to have a bowel movement. That is completely normal, but I assure you that is not the case. It's simply that enema tip pushing against the rectum and against the muscle that makes you feel like that. That will subside within a minute or so. Say something like that to the patient. Let them know what's going to happen so that they're not completely clueless. Wearing gloves, I would tell you personally, I put on 2 pairs of gloves. Why? Because if you've ever tried to put gloves on after your hands are sweaty, it is near impossible. So I put 2 pair on, And then once I get the enema tip inserted, I take off the top pair so that I have a second pair ready to go and they're already on. You don't have to do that. You can do it however you like, but you definitely want to have gloves on while you're tipping the patient. When it says drain air from the enema tubing, ideally you've done that when you mix the contrast. You just want to get as much air out of the line before you actually put it in the patient. And always lubricate the enema tip. We have stuff called Surgilube, typically that's almost like a clear, has a consistency, I would say, of like petroleum jelly or Vaseline jelly. You would put that on the enema tip. I've used lidocaine jelly before so that it kind of has a numbing effect because some of these patients, the rectum is irritated from all the bowel movements they've had. Some patients have hemorrhoids that are extremely painful. Whatever protocol is for your site, but you definitely want to have lubrication on the tip before you insert it. Now, enema tip insertion, they tell you that the initial insertion is up and towards the umbilicus, and final placement, it's a little bit anterior and then superior. Now, I don't know about you, but when you look at that, it sounds kind of overwhelming. This is on page 505. Okay, I'm going to tell you, this is not rocket science. Putting an enema tip in, you as the one inserting it, are not going to have to think about this. Once you start to put the tip in the patient's rectum, it's kind of going to go in on its own, like it's going to guide itself in. There's no thought really involved with that. The only thing I would tell you is you never ever want to force the tip in. If it doesn't go smoothly or easily, then you wait and let the radiologist actually insert the tip under fluoroscopy, because you don't want to, the potential to perforate the rectum is very real, and you don't want to be the one to do that. Okay, so now are you going to have to put that tip in and go against a sphincter? Yes. Most patients do not like this portion of it. They tend to tense up. They tend to clench their butt cheeks. You have to try and get them to relax. You tell them to breathe in their nose and out their mouth. You try and get them to do that a few times, and then you're actually going to insert the tip upon exhalation. Okay, the tip gets inserted upon exhalation phase. Why? Because they really can't push against you at that point, and it's a little bit easier. The sphincter tends to relax a little bit. Okay, so if somebody asked you, how is the enema tip inserted? What direction? It's directed up and towards the umbilicus. So it's going up, like towards the patient's head, and then slightly anterior towards the patient's belly button. So it's up and towards the umbilicus. Okay, and that tip only goes in approximately 3 inches. It doesn't go very far in, but you have to go beyond the retention balloon because you're going to inflate that. So you don't want to inflate that in the rectum or in the sphincter itself. You actually get that tip in. And then this is also on page 505. Okay, so the tip is lubricated. You're telling the patient to breathe in their nose, out their mouth. When they blow out, you insert the enema tip in. It guides itself. It stops. At that point, we are allowed to put in 1 puff of air. Your book says 1 or 2. I am telling you we are allowed 1 puff of air. If it requires 2, that is only done under fluoroscopic guidance with the radiologist in the room. Okay, only under fluoro, because you don't want to perforate the rectum. So you're allowed to put 1 puff in. Once that 1 puff of air is in the patient, then you have that patient roll back onto their back. And ideally at that time, either you've let the radiologist know that you're almost ready, and then he or she would come in, or at that time you would let them know that you were ready, and they would come in. Now, most people say, how can you inflate that balloon and lay them on their back? The best way I can describe that is you've got to imagine this is actually in the patient's rectum, right? So it's up in here with the balloon inflated. So it's not like it's going to push against the table. There's nothing to actually prevent them from laying on their back with that balloon inflated. All right, so the the tip is inserted up and towards the umbilicus, and then one puff of air allowed, and then the radiologist comes in. Now, they also go ahead and tell you that, we're going to look at this in 1 second. On 505, they tell you that during these procedures, whether it's a single contrast, a double contrast, during a single and a double BE, the flow of barium is started and stopped multiple times during the exam. How do we know when to start and when to stop? The fluoroscopist or the radiologist will literally say, barium on, to which we repeat, barium on, and we unclamp the bag and allow the barium to flow. When he or she wants it stopped, they will say, barium off, and we repeat, barium off, and we clamp it. Now, why do we have to repeat what they say? It's basically done so that they know we heard them. In case we heard them wrong, then they can correct us, or just to confirm that you've understood and you're doing what they asked, whether it's being turned on or turned off. But every time they say that, that is what you do. You repeat it and you either unclamp if they say barium on, or you repeat barium off and you clamp it. And we do that until they are done with the procedure. So this is a little more involved in that you're trying to help the patient, make sure they're rolling the correct way. You also have to watch the tubing because this is coming out of the patient's rectum and it is down the table. Let me find this slide and show you what I'm talking about. Do you see how this is coming down the table and then up to the bag? Now, typically that pole would be like right here so that the tubing is going like this. But regardless, when this patient rolls, their legs, you don't want their legs to get caught up in the tubing, because if that's the case, what can happen is that they can actually pull the tip out because of the fact that they because they actually pull it out with their feet. So we are turning the barium on and off. We are watching the tubing. We're watching the patient. We're listening to the radiologist, and we're trying to watch the monitor. Now that sounds very overwhelming, and I'm quite sure listening to lecture and looking at the book, everything about it is overwhelming. But I promise you, once you go out into the field and see this, it's very smooth. It's not near as bad as what it sounds like or what it reads like in the book. It's actually a lot easier than what it sounds like. All right, on a single contrast barium enema. Okay, that's all we're going to talk about in this lecture is the single contrast BE. I will tell you on page 506, they reference that a single contrast enema is a procedure where there's only positive contrast media used. And typically it's barium sulfate, but occasionally it might be the water-soluble contrast media. That would be for any of those three contraindications: possible obstruction, possible perforation, pre or post surgery 48 hours either way. Okay? And what the book does not tell you, but I want you to make sure you know, is that in a single contrast enema, whether it's barium or the water soluble, we use 2,500 cc's or 2,500 milliliters. Those are the same measurements, 2,500 cc's or 2,500 milliliters of contrast for a single contrast BE. When we talk about the double, I'll let you know what that is. Notice this is a single. How can you tell? Because there's solid barium filling that lumen of the large intestine. Like there's hardly anywhere, like right here you can see there is a slight amount of air in there, but if this was a double contrast study, it would not look like this. This is completely a single contrast BE because the entire lumen of the entire large intestine is full solidly filled with positive contrast media. Some of the safety concerns for a BE. You have to make sure you review the chart or the requisition. You never want to force the enema tip into the patient ever. You never want the bag higher than 24 inches above the table unless the radiologist is directing you to, because sometimes if the contrast is not going in, they will ask you to raise it, but only under the direction of a physician should you do that. You want to make sure the water temp that you use to mix the contrast is not too hot and not too cold. And when the patient gets up from the table near the end to go to the restroom, make sure you escort the patient because they've had a lot of barium. And this is very overwhelming on the patient, and you don't want them to get dizzy on the way to the restroom and pass out. For a barium enema series, your SCOUT image is the first thing that you do on this patient, and that is an AP supine abdomen, whether it's, like I said, 1 14 by 17 lengthwise, a T-shot, or 2 14 by 17 crosswise. But you're doing an AP supine abdomen SCOUT to ensure that the patient has followed their prep and that they are cleaned out. You need an enema tip. You're going to do fluoro, and then once you do the SCOUT and you tip the patient and you go through the fluoroscopy procedure, then the doctor actually leaves the room. At this point, once you've done your SCOUT, you tip the patient, the doctor comes in. He or she does all the fluoro. This is where you're controlling barium on and off, you're helping the patient, you're assisting the doctor, and then at some point they're going to say barium off and they're going to leave the room. No more barium goes into the patient at that point. Now we are tasked with doing our overheads. Okay, remember, overheads are the images taken after fluoro. And for a single contrast BE, we do an AP axial or an AP axial oblique, which is called a butterfly shot. So we do one of those. I'm going to show you, I think the AP axial is typically what is done. Then we do an AP, some facilities do PA, but we go AP axial, AP, and then we don't do AOs because it's not our protocol. We do LPO and RPO. Then we put the patient in a left lateral rectum. After that particular image, we check the images and we let the patient go in the restroom and empty as much barium as they can. And then they come out and do an AP post-evac. So the routine on your cheat sheet should read AP axial butterfly, AP, LPO, actually it probably reads RPO, LPO, left lateral rectum, post-evac. Now, the AP axial butterfly, this is actually found on page 523. Okay, on 523, I can tell you that these facilities that we use as clinical sites do this particular image. Advent Health Waterman, Central Florida Regional, and Advent Health Daytona all do these particular images. The AP axial oblique that is also on this page, Advent DeLand actually does that. So I'll show you both of these, and we can look at these. So write that down. The AP axial is Advent Waterman, Advent Daytona, and Central Florida Regional. Advent DeLand does this particular image right here. This is Advent DeLand. Advent Waterman, Advent Daytona, and Central Florida Regional do this. Okay, so on this particular image, these are all 14 by 17s lengthwise, assuming your patient fits that way. If it's a hyperstenic patient, for some of these images, not this one, you might end up doing 2 crosswise. So for the AP axial, patient lies flat on their back. The central ray is angled 30 to 40 degrees cephalic or towards the patient's head. And for the AP axial, the central ray is 2 inches below ASIS and midline. So this central ray right here is 2 inches below her ASIS and midline. And the purpose of both of these is to straighten out the sigmoid colon. Remember, the sigmoid colon has an S shape to it. So these particular images will actually straighten it out so that the radiologist can get a better view of that, not all coiled up on itself. So the AP axial lies flat on their back. Central ray is 2 inches below ASIS and midline. Central ray is angled 30 to 40 degrees cephalic. And notice you're still lining everything up. Still have to be aligned for that. The AP axial oblique, or the LPO, for that particular image, the patient is rotated 30 to 40 degrees into an LPO, or a left posterior oblique. The central ray is 2 inches below and 2 inches medial to the right ASIS. Okay, 2 inches below and 2 inches medial from the right ASIS. And again, the tube is still angled 30 to 40 degrees cephalic. This particular image is what Advent Land likes to do. And the purpose of both of these is to straighten out the sigmoid colon. Now, the technique, if it's a single contrast BE, meaning you're using barium or the water-soluble iodinated, your technique is 125 kVp at 3.3 mass. If it's a double contrast, I'm so sorry. If it's a barium, only if it's barium are you doing 125 at 3.3. If it's the water soluble, because it has a lower atomic number and it's less radiopaque, or a double contrast study, then you're only going to use 100 kV at 3.3. So single contrast, barium, 125 at 3.3, double contrast or water soluble is 100 at 3.3. And what these images do is actually straighten out the sigmoid colon. So this is the AP axial. Okay, you can tell by the pelvis that the central ray is angled. It throws everything up and straightens it out. And then this is the AP axial oblique, or the LPO. And you've got the rectum here and then the sigmoid colon here. Again, straightened out, not all on top of each other. So this is one for Advent Daytona, Advent Waterman, and Central Florida Regional. This is Advent DeLand. But both of these images are done to straighten out the sigmoid colon. Okay, you can also see, nowhere we have does these, but if you look on page 524, you could also do the images to straighten out the sigmoid as either a PA axial, which is this one, or a PA axial oblique, which is an RAO, which is this one. We do not do those. We only do one. Oops. We only do one. We either do this one, or a facility do this one or this one. So there's 4 total images that will straighten out the sigmoid, but you only do one of them, whatever protocol is for your particular facility. Okay, and that's the evaluation of the PA and the PA axial. Again, straightening out the sigmoid colon to get a better view of everything. Then what? After we do the AP axial, we do an AP. All right, and this is actually found on page 515. All right, and we do the AP. So all that happens from that first AP axial to this is you take the angle off the tube and you realign to your Bucky. Patient stays exactly how they were, just flat on their back. And the central ray now is at iliac crest. and midline. Okay, iliac crest line. The technique on this, if it's just barium, it's single contrast, it's 110 kVp at 2 Mass. If it's a double contrast study or the water-soluble iodinated contrast, you're going to use 90 kVp at 2. All right, and that is again on page 515. And this is what your image would actually look like. So patients just lying on their back, and you can see the tip down here, rectum, sigmoid, descending colon, left splenic flexure, transverse, right hepatic, ascending, cecum. Okay, and notice how the transverse kind of flops down on this particular patient. All right, so we've done AP axial, AP. Next we do our obliques. We would do RPO and LPO. And just to keep less patient movement, we would likely do the RPO first and then have the patient do the LPO. And these are actually found on page 518. The patient is going to roll into an oblique. You can use that oblique sponge. And they're in a 35 to 40 degree oblique for this. Actually, in the book it says 35 to 45 degree oblique, so make sure you go ahead and fix that. I did not type that, but it's 35 to 45. So just like a 45 degree oblique like we did on the upper GI. Central ray is iliac crest and 1 inch lateral to the elevated. Now what does that mean? It's at the level of the iliac crest, so it comes across the crest this way. This line, instead of being midline, like let's assume midline is right here, you don't want it midline of the patient, you want it 1 inch to the side that's up. So in this particular image, it would be 1 inch to the right. In this image, her left side is up, so you go from midline 1 inch to the upside. Usually how I say it is you're 1 inch to the upside at the level of the iliac crest. And I can show you that. You can watch the videos under this particular exam, and it will definitely demonstrate that. The purpose of these obliques is that whatever side is up, it opens that flexure. Okay, so this one right here, she's in an LPO. So the side up is the right side. So this would open the right hepatic flexure. This is an RPO. So the side up is left. It would open the left splenic flexure. Okay, now I can tell you we don't do AOs, but it would be the opposite on the AO. It actually opens the downside flexures on the AOs, and those are on page 516 and 517. So when the patient is in an RAO, all right, the right side is down, so it would open the right hepatic flexure. If they were in an LAO, it would open the left splenic flexure. All right, technique on the POs. If it's single contrast, just barium, you're 110 kVp at 2 Mass. If it's double contrast or water soluble, it's 90 kVp at 2 Mass. And this is what the images actually look like. On the LPO, so you've got right side up. Notice how the right iliac wing is foreshortened, and from what you can see of the left, it's elongated because the left side is down, but it straightens out this right hepatic flexure. Okay, look how the left is all twisted on itself, but the right is nice and open in the LPO. In the RPO, where the right side is down and the left side is coming up, notice now the left splenic flexure is nice and open compared to how it was over here. Over here, can't get a lot of information out of that. So that's why we're only looking at this one. But in the RPO, it opens up. So that's the purpose of the POs and the AOs, is to open the flexure. On the POs, you open the upside flexure. On the AOs, you open the downside flexure. What's next? Next is our lateral rectum. Now this ventral decube comes into play for a double contrast BE, so we're going to ignore that for now. That's this particular image, goes with this. We're not going to talk about it. All we're going to look at is the left lateral rectum. Okay? Notice she's in a left lateral rectum, and that's the one we do. It's literally the left lateral rectum. So add that. This is on page 519. Okay, you want to make sure the patient's in a true lateral. Remember we said for a lateral, you want their back straight, hips and shoulders on top of each other, knees on top of each other, ankles on top of each other. Okay, central ray is perpendicular, and the central ray is at the level of the ACES and mid-axillary. So coming right down the middle of the patient. In this particular view, it does not matter how big their rear end is, because the rear end, a lot of times, if they have, I usually say if they're big booty Judy, that is all adipose tissue. That is not, it might be muscle, but it is definitely, just because they have large butt cheeks, it does not mean their rectum moves. Their rectum is typically still mid-axillary. So don't get fooled by the size of their rear end. You want to stay mid-axillary for this line, and this line is at the level of the ACES, not the crest, the ACES, because you're trying to get rectum, which is lower. So ACES and mid-axillary. Okay, don't pay attention to this. This is just true lateral, ACES, and mid-axillary. Now, if it's a single contrast enema with barium, you are at 110 at 20 mass, 20. Okay, because they're a lot thicker like this than they've been up to this point. So 110 at 20 mass for a single contrast. If you were double contrast or the water soluble, it's 90 at 20 mass. And this would be your image. Notice you've got lateral rectum. You can see sacrum right here, coccyx, head of the femur, in the acetabulum of the pelvis. Notice you can see the retention balloon full of air and the retention tip. And then this is the rectum that we're looking at on this particular image. All right. At this point, once that image is taken, you would then have someone, or they've probably already been looking at your images as they come out, but at this point, all the images are evaluated to see if you need anything else. If everything has come out up until this point, then what you do is you get the patient, well, let me start from the beginning. What you would do is leave the patient on their left side. You would place the enema bag on the floor and undo the clamp to allow the barium to drain back into the bag as much as it can. This will give some relief to the patient. It'll take pressure off their intestine, and you allow the barium to flow back into the bag. Once the flow of barium has slowed down or stopped, you would clamp the bag. You would remove the air from the retention balloon and slide the enema tip out of the patient, throwing all of that enema bag and tip away. You would not throw out the clamps that you clamped off the tubing with, and you would not throw away the balloon inflator that blows up the retention cuff. Those two things you would save. Everything else you throw away. You would get the patient up off the table, escort them into the bathroom, and tell them to empty as much barium as they can while they're in there. Just let them sit, relax for a few minutes, try and get rid of that barium, any air that might be in there. Basically, while they're in the bathroom, you're cleaning up the room and you're getting ready for your post-evac image. Okay. Now your post-evac image can either be an AP or a PA. Typically, I like the patient AP because it's just easier for them to lie on their back versus their stomach. But if where you are protocol is PA, then we place them PA. If it doesn't matter, it's easier to place the patient AP. So once they're done with that, you get them back up on the table, and you would have them lie on their back or on their stomach. And this is on page 522. All right, you have to include the entire large intestine, and what you're looking for is to see how well the large intestine emptied. All right, you're trying to make sure that most of this came out. Now, why they have an enema tip in the patient for a post-evac is because some facilities only allow drainage back into the bag, and then they clamp and look with the tip still in the patient. Most everywhere we utilize, I don't know anywhere that does it like this. What we do is remove the tip, let the patient go into the restroom, and when they come back for their post-evac, this is not present. Okay? So patient lies on their back. Central ray for this is at iliac crest and midline. You can see right here, iliac crest and midline, right? The technique for single contrast barium only is 110 kVp at 2 mass. If it's double contrast or water soluble, it is 90 kVp at 2 mass. And again, you have to include the entire lower intestine because it is possible if they have too much barium left, they sometimes can ask the patient to go back into the restroom and empty more and come out once they've accomplished that. Because if there's too much left in them, then they can't really evaluate that the patient's going to be okay to empty the rest on their own. So it is possible you have to take a second post-evac. Okay, once you get that image out and it's good, you get that cleared with someone, then you would bring the patient back to the dressing room and allow them to get dressed, and you would give them their post instructions, which are always 8 to 10 glasses of water in addition to what you normally drink until your stool returns to normal. And that could be anywhere from that same day up to 24, 48 hours beyond the exam, totally dependent on their system. Do not tell them to increase their fiber. Do not tell them to take any laxatives. Just encourage water consumption. If they have any questions other than that, they need to contact their physician that ordered the exam. And you could let them know that their physician will have those results in 24 to 48 hours.